thrilled to welcome today Dr. Ryan Maves, who is a professor of medicine and anesthesiology at the Wake Forest University School of Medicine, where he's an attending physician in the sections of critical care medicine and infectious disease. He retired from the United States Navy in 2021 at the rank of captain after 22 years of service. Thank you. And he joined the Wake Forest University School of Medicine at that time. He's board certified in internal medicine, infectious diseases, and critical care medicine. So you might imagine that the last few years of his life have been a little bit interesting. And he's here today to talk to us about some of those experiences. He graduated from the University of Washington School of Medicine, where he completed an internal medicine residency and fellowship in infectious disease, subsequently at the Naval Medical Center in San Diego, California. So please join me in welcoming Dr. Maves, and thank you so much for being here.
Hey. So what we're going to talk about today is crisis standards of care, and we'll give some definitions of that. But this is sort of where, you know, the point where bioethics and the practice of medicine reach their, one could argue, most extreme point. And the challenge that we faced during the pandemic, and I think going forward for further future public health emergencies, is what do you do when you're out of space? What do you do when you're out of gear? How do we, not who gets what resources we have, and those resources are limited. And this is a kind of a continuous problem. Well, while they're setting that up, just a quick description of kind of what I do and our background is. So for the undergrads in particular, so I'm a critical care physician, which means I specialize in care of patients in the ICU. So when I'm not doing that, I specialize in infectious diseases. Most critical care physicians in North America are trained in pulmonary medicine. I took a somewhat different pathway. And while I was in the military, academic military physicians in critical care tend to kind of get placed into this sort of disaster and bioterrorism, biodefense ghetto that where I spent a fair bit of my research time. And then when the pandemic hit, I was running a research, an NIH-funded research group in San Diego, where we wound up becoming one of the platforms for the adaptive COVID treatment trial, which was the trial that led ultimately the FDA approval of a number of drugs that we now routinely use for the treatment of COVID-19. We also ran our group also ran the AstraZeneca vaccine trial, the phase 3 for that, which I got to say, it was a good study. It's nice to have a New England Journal publication out of it if you're an academic physician, but I think we kind of hitched our cart to the wrong horse in that particular vaccine, but a good study is a good study. So what we're talking about today is crisis standards of care. So in crisis standards of care, the idea behind it, this is a catch-all term that was first defined in an Institute of Medicine report, and when we get the slides up, I'll kind of cruise through this part, is the idea that in public health emergencies, the healthcare system may reach a point, and in the pandemic did reach a point, where our available resources did not meet the demands of patients in need. And generally, this also implies that there is a time-limited nature to this, right? One of the features of critical illness is that you're very much on the clock. When we look at studies, for example, the care of patients with sepsis and septic shock, the amount of time we have to administer antibiotics in those patients without increasing their mortality is measured in an hour. It's measured in an hour. In patients who present to an emergency department in shock due to infection, we have an hour or less to administer antibiotics. When patients are decompensating from a respiratory standpoint, I have minutes on average to get them intubated, secure their airway, and get them on a ventilator. So we have to make these decisions relatively rapidly. So in the around 2010, the Institute of Medicine put out a report describing this concept of what we call crisis standards of care, which is to say, if you're going to simplify it, if you got 10 patients who need to be intubated and you have 5 ventilators, who gets those 5 ventilators? How do we decide? This really first came up in the context of the H1N1 influenza pandemic in 2009, 2010, where there was this very large-scale surge of patients. And so these plans were built around this notion of what do we do with the last vent, who gets the last ventilator, and how do we decide? So a lot of plans were put into place that were then ultimately developed and implemented on some level during the COVID-19 pandemic. And so one of the things we'll talk about is what was the basis of those plans and did they work? And I'll give you a short answer, not much and kind of. So just to kind of start off, everyone is wrong sometimes. So at the beginning of the pandemic, this was in February of 2020, various professional societies have their annual meetings. And I was speaking at I got asked to give a talk about this new coronavirus thing emerging in China at the February 2020 meeting so this is like right before the world ended, right? Of the Society of Critical Care Medicine. And so I have this slide that I show, and I saved the slide because I like to look back at it as a way to humble myself. And I actually gave this talk on the day COVID was named. Whoops. This can wait. And what I said was, these are some potential interventions we can try for COVID. There's this drug that was trialed in Ebola called remdesivir. Seems like that might have some benefit. We probably shouldn't use steroids because we've looked at similar diseases like severe influenza and SARS, and steroids don't seem to help that, so we shouldn't use steroids right now. And that we need to have a better way to have standardized data collection for looking at large-scale trials. So then I look back at that and I'm like, well, okay, shouldn't use steroids for COVID. Well, that turned out to be totally wrong. That was absolutely wrong. So there's a video of me saying the thing which is totally disproven, right? Remdesivir, yeah, that was kind of helpful. Some other drugs that I cited were not particularly useful, and so forth. So that gets us into what is the definition of crisis standards of care? So there's a quote from the Institute of Medicine which says, crisis standards of care is in an important ethical sense, entering a crisis standards of care mode is not optional. It's a forced choice based on the emerging situation. Under such circumstances, failing to make substantive adjustments to care operations, that is to not adopt crisis standards of care, is very likely to result in greater death, injury, or illness. Right? So the idea was that unless we adapt how we care for sick people in large volumes, we will hurt more people than we would have if we made potentially difficult choices. Right? So that was the concept. So the goal of crisis standards of care as a notion, is that we try to do the best possible job in meeting some sort of standard of care in a time of crisis. Right? So the goal of this is not, for example, to provide less care to patients. The goal is not to decide who is to live or to die. The goal is also not to reduce our ethical burden to patients, right? That this burden continues no matter how we adapt our care processes. So when we talk about this, there are traditionally three kind of pillars of resource allocation, right? So when we're talking about this, almost feel like I should have a board to write on at this point. It seems like this would be somewhat helpful. Okay, so there are three sort of pillars of resource allocation when we think about how we deal with shortages in healthcare, all right? There's stuff. Okay, so stuff is like ventilators, right? So if everyone remembers 2020, we were all petrified we were going to run out of ventilators in hospitals. And quite frankly, we nearly did. I have a couple friends who came very close. This could include dialysis machines. This could include various consumables like drugs, or PPE was a big deal, right? I was issued 5 N95 masks, and I had paper bags, and I had to rotate my N95 every day, right? And so that's, N95s are single-use items, right? But I had my 5, and I'd write down the date that I used one, and I would just wear it all day, and then at the end of the day, I'd put it in my paper bag, and hopefully it'd be okay. So stuff. Next one is staff. And so staff obviously refers to us, the people, right? Physicians tend to have sort of a physician-centric view of how medicine works. But the truth is that, you could probably replace me with a somewhat trained monkey. But, if we run out of nurses or we run out of respiratory therapists, that has a much more dramatic impact on our ability to care for patients. Then space. This can be physical beds, physical ICU beds, physical beds in the hospital wards, the emergency department, but we can also get creative with this. So a lot of places, for example, we would move the ICU into the post-anesthesia care unit, which is set up like an ICU. Or occasionally we'd just push people all the way into the operating room and run ICU patients out of the OR. They have ventilators in there, they have monitors. We can do all of this stuff in that place, okay? So those are the big three. Then there's sort of this overarching notion of systems by which we organize care. Okay, so when we think about crisis standards of care, then there's sort of 3 tiers. Then these are just, these are just organizational constructs, right? What's a friend of mine said once? It's a good line, I'm trying to remember, it's very pertinent right now. Anyways, I'll come back to it. Okay, So conventional is sort of normal operating, right? We can get busy under conventional features. And typically we are running pretty close to the limit of how much space we have in a typical ICU, right? Like at any given time, at all of Baptist is a 900-bed hospital. There are 150 ICU beds there, right? We maybe have like 3. When I'm on call at night, I check to see how many beds I have open for admissions, and it's usually like 2 or 3 in the building for adults, right? So conventional is where we have all the stuff we need. Contingency is then when we have exceeded that limit, but we can still pretty much function normally, right? So an example of contingency would be, you figure an average hospital can increase its capacity by about 20% using available resources. So in that setting, we have to reuse, we have to adapt, we have to try things that are within the standard of care, but maybe not like plan A. So an example would be analgesia and sedation. So being intubated is uncomfortable, right? Being intubated is anyone, just out of curiosity, anyone had a friend or family member who's been on a ventilator in an ICU? A fair number of us, right? It is not a pleasant experience. And so we have to generally give people medication to keep them from being too miserable. Usually this is done intravenously. When we started running short on intravenous sedatives, we would switch to oral. And we'd put them down an oral tube and kind of put them right in their gut. And that actually worked okay. And it turned out, in retrospect, that may have been a better practice. All right? Then crisis. Crisis is when everything breaks, right? There is just not enough. Excellent. Okay. And these are our categories: conventional, contingency, and crisis, right? So the challenge we had during much of the pandemic and sort of the healthcare system globally, but particularly with the United States, for us, was that we were in a chronic contingency state, right? All of the plans we made assumed a somewhat time-limited disaster, not 2.5 years, right? We planned for like shootings and floods and hurricanes and earthquakes, and maybe a disease outbreak that lasts for a month or so, right? But no one planned for 2.5 years. So this is kind of an example of how you'd organize care. This is from a 2014 paper by John Hick and Sharon Einov. Sharon is actually, she's a friend of mine. She is an Israeli intensivist, so she's having a bit of a week right now. I spoke with her yesterday. Conventional, contingency, and crisis, right? And so we see space, for example, under conventional, we use usual spaces. Contingency, we adapt other spaces like a post-anesthesia care unit. And then in crisis, we're using the hallway, right? We're using tents outside the building, which did not happen in Winston, but did happen in California where I was practicing at the time. Now, this is sort of an oversimplification. This is perhaps a more sophisticated version that we did for a 2020 paper, where we say you can move in and out of this, right? Depending on what level of crisis you happen to be in at a given time, right? You can impose triage at different levels depending on the flow of patients at any one time. And we saw this throughout the pandemic, where things would calm down and then things would get ugly again. And then they would calm down and they would get ugly again. And we went through this about 4 times. The first initial wave, and then things kind of died down. And then the winter of 2020 got super duper ugly. And that was the biggest spike of patients in terms of death. And then the Delta wave in 21, and then the Omicron wave right after that. So when we think about disasters and different problems with disasters, pandemics are a little different than more, shall we say, conventional disasters. So like an explosion or a natural disaster, or, God help us, a mass shooting, casualties can be very high. They can be as high as the hundreds. They're usually trauma patients. They usually go to the nearest hospital. The people who are in the greatest demand from a specialty standpoint are emergency physicians and emergency nurses, surgeons, and mental health services, actually. And the recovery, when you start building back from this, is pretty fast. This comes in the first few days. A pandemic, COVID-19, Ebola, H1N1, casualties are in the thousands or greater, over 1 million deaths in the United States alone. Mostly medical patients, meaning people who don't need an operating room, meaning you have a lot of underemployed surgeons snarling and walking around. You have to give them something to do. You get very antsy if you don't. All right. They present in many hospitals, and it can be hard to move people because the demand is everywhere, right? If there is a mass casualty in Winston and Baptist is full, we can transfer patients. We can transfer patients to Cone. We can transfer patients to UNC, to Charlotte. With COVID, we couldn't. There was no place to send anybody. Emergency and inpatient services, particularly critical care, in the greatest demand, and the recovery is, well, shall we say, ongoing. So that gets back to those pillars. What about stuff? So the scope of the contingency can make the shortages we deal with chronic. They can be difficult to reallocate equipment between more or less affected areas. We try, and this is the thing I hope, and some of us are kind of arguing this in various societies, to shift from single-use to reusable equipment. Like, do you know what like a bronchoscope is? Everyone have a colonoscopy? So a bronchoscope is a colonoscope for the lung, right? They're disposable now. They used to be reusable. Now we have single-use bronchoscopes, which, I mean, honestly, as an environmental extremist, you know, that makes baby Jesus cry. The problem is that we burn through them and we run out, right? Staff, so caregiver fatigue, right? I will tell you, during the last big surge, which was the Omicron surge, I have never personally been more nihilistic than I was in my life. And I've been to war, right? Like, I've been shot at. And by Omicron, things got dark. Things got super dark. The heroic phase of the pandemic had ended. Personal risks. Early on, that was a big deal. Later on, not such a big deal. Then lastly, increasing experience. There's an upside to this, is that by the later phases of the pandemic, we were all pretty good at this, right? We were all, very experienced in taking care of these patients. We knew the disease. We knew how it went. We knew how to react. We knew what to expect. Then space. We actually were able to generate a lot of extra space. We converted a lot of ward beds to ICU beds. We turned, a buddy of mine, back when I was in the Navy, turned an entire floor of our hospital into a negative pressure room. And also people got more used to taking care of sicker patients outside of the ICU, which helped. So how do we respond to these surges? What do we do? So the whole point of surge responses, and when we adapt hospital responses, the point of it is to increase health system capacity in an emergency to avoid the need for crisis standards. Like, no one wants to do triage. No one wants to allocate the last ventilator. We try to avoid it. So in these settings, normally we're looking at normal standards of care. So we have different techniques. We expand the acute care workforce. So we take people who are, for example, not ICU doctors, but went through an ICU a couple times in training. We kind of beef up their skills as quickly as we can. We put a few of them under the supervision of a single intensivist, a single critical care doctor, and then we make do, right? We make do, and that actually works okay. We have little charts, like you have, one ICU doctor and nine ICU doctors, and it actually works okay. It actually it gets you through the emergency. We use a lot of telemedicine when we have to. This is a model that can be used where you have, one adult ICU doctor, there's a couple ICU nurses underneath them, and then there are sort of a spread of different people involved. In this case, this is a model of how, if a pediatric ICU got overrun, how an adult ICU doctor could help take care of kids. Pediatricians will often tell adult doctors that kids are not little adults, and I'm like, well, I mean, when they're 10, they basically are little adults. But figuring out a way that we can expand care for children as well, it uses the same model where we have a pediatric specialist overseeing a bunch of adult specialists so we don't do too much damage in the process. Now, space, we talked a little bit about this, but the idea of space is we find places that at least have adequate monitoring and adequate equipment to care for someone, but not in the usual place, right? And so an example would be a tent hospital, right? For patients who are relatively stable, who required oxygen, some monitoring, but not a lot of invasive procedures, nothing like that, we could set up a field hospital outside. And out in El Centro in California, which is where it's a couple hours east of San Diego where I lived, they set up a number of tent hospitals to care for an overwhelmingly Latino population that was just getting shellacked by COVID, and that worked reasonably well. So drug shortages in sort of the developed world are a constant ongoing problem. And it's every time I come on service, I discover some new, what is the shortage this week? For a long time it was ketamine, which is a commonly used sedative in the intensive care unit, and also hilariously a drug of abuse. Almost every drug I use, professionally, not personally, it has street value now. And propofol, which is our main sedative, all my patients are like, isn't that what killed Michael Jackson? And I'm like, well, yes, but. So we had to figure out a way to mitigate these shortages. And this is an ongoing problem, but is clearly exacerbated in times of crisis. So there's this thing called the FDA Essential Medicines List. And that's a point of reference, but it's kind of a weird list. There's 4 drugs that will provide what we call neuromuscular blockade, when we have to paralyze people temporarily. There's like 4, those drugs are interchangeable, so I don't know why all 4 of them are essential. There are 3 fluoroquinolone antibiotics, which are largely interchangeable drugs. There are short, anyways, there's some oddities in the list, but it's a good starting point if you're trying to figure out in a resource-constrained setting, what are kind of the core things I need to make a hospital work. Then ventilators. So this was a big deal. So there's a thing called the Defense Production Act, which allows the federal government to like take over GM and build, tanks and things like that, right? But so this was used in 2020 by the previous administration to create ventilators. But it turns out that having people who don't know how to make ventilators doesn't work as well as you think. So 200,000 ventilators were made, but only 60,000 of them could actually care for someone with advanced respiratory failure. But still, at 60,000, I mean, that's not nothing. I don't want to totally say that that was a waste of time, because there are a lot of people who are on ventilators who don't have them because their lungs are bad. So like neurosurgical patients, for example, will often require mechanical ventilation. And some of those vents would actually work okay for those patients. And that would free up then a full-featured ventilator for someone else. So it wasn't a complete waste of time. And then, of course, limitation is people who know how to run a vent, right? There are only so many of us. So what was the impact? So why does this matter, right? If I just say, like, we had this big surge of patients, I mean, and that means I work more, I don't think people care that much, right? I mean, that's, your sympathy touches me, but the truth is that if I have to work harder because there's an emergency, that's okay. I mean, that's my job, right? But why does it matter to the world? So Samir Qadri, who's another ID critical care doctor at NIH, did the study. This was the Annals of Internal Medicine, and this is very, very highly cited now. Basically what he did is he looked at what was the impact of surge on mortality at a hospital level, right? That is, as a hospital census increases past what it should be, and you normalize mortality, there's a predicted mortality rate, right? And when I have residents who ask me, or like, I'd like to do critical care, I'm like, great, that's lovely. One of the things you have to understand is that 25% of your patients are going to die, right? And that's not a bad number. And so you have to get used to that. You have to learn to live with that. What this study showed was as hospital censuses went up above what they're supposed to be, mortality increased. That is, the busier you were, the more patients died. And it's not just the raw number of patients, because if there's more patients, there's going to be more opportunities for people to pass away. But an individual patient's risk of death went up, right? So surge kills. And that's the thing we've been trying to avoid. This was a CDC study that showed essentially the same thing. So one of the ways we try to mitigate this is the idea of regionalization of care, right? Hospitals, and in the United States, hospital systems are often in competition with each other, which is not true everywhere. Everyone gets together and says, okay, you're full, I have some space, let's load balance. Let's transfer patients between each other, and entities that are normally in competition with each other can then collaborate a little bit. And if that spreads the patient load out, then everyone's mortality gets better. Right? So this is good for the hospital, this is good for patients, everyone wins. But it really needs to be organized with some level of government involvement. So in Washington State, where I grew up, it worked pretty well. In Minnesota, coincidentally where I was born, also worked pretty well. North Carolina had a little more of a problem with it, to be honest with you. And collaboration, even within our own system, was a problem. It got better over time. This is just a model showing how these groups can interact with each other. All right, so let's say all of this fails, okay? All of this fails and we are left with triage. So the notion of triage is essentially one of the greatest good for the greatest number. But what does that mean? How do we decide what that means? Is it just raw numbers of people alive? What types of people? How do we make sure there's equity in that? The basic problem with triage is when demand exceeds supply. So when we're looking at a public health emergency, we can use therapies on the far left, that's TX is an abbreviation for therapy, to try to reduce demand by keeping people from getting sick. We can use public health control measures like masking in public, like vaccinations to reduce demand. On the supply side, we can increase staff, we can augment our supply availability with things like, conserving gear, readapting gear, reusing gear when safe and practical. We can increase space. We can do all these things to shift this supply-demand balance a little better. So like I said before, surge responses should seek to avoid the need for triage when all the other stuff fails, to the greatest extent possible. Most of the writing about triage in the context of what I do for a living is focused on ventilators, but there's actually a wide variety of things that can be triaged, if you will. So in New York, at Bellevue Hospital at the beginning of the pandemic, in the United States anyways, it was dialysis machines. And a good friend of mine is actually the medical ICU director at Bellevue. And I remember texting him a few days into it. I'm like, hey dude, how you doing? And I get one line back, which was, and I quote, and I apologize because I'm on the tape, said, "What the hell, man? What the hell?" That was his entire response. In his case, it was dialysis machines, and CRRT is a type of dialysis machine used in critically ill patients. And so what they had to do was adapt strategies, because dialysis is like usually time sensitive, but it's usually not like minute to minute time sensitive. And so they could stretch it out. Like CRRT is supposed to be dialysis that runs all the time. But maybe we could use that same machine in 2 different people and just run them each 12 hours a day. And that's probably not perfect, but it's probably pretty good, right? So that was a strategy that could be successful. Remdesivir. So remdesivir was the first FDA-approved drug for the treatment of COVID. But when it first came out, there was very, very little of it. And so in San Diego County, we set up kind of a collaboration between all of the health systems, between the military, the VA, the private systems, the university, to kind of share between each other. And it was actually really heartwarming because the guys, like there's this one guy who's the ICU director at a very fancy private hospital in a very fancy part of town. And he said, honestly, I don't need this much of this. If I just have a few courses, I'll be okay. The people working down next to the border are the ones who really need this. And that worked out really well. So there's different kind of ethical concepts, and it occurs to me this is a bioethics talk, so I should probably talk something about bioethics. Triage systems seek to identify patients most likely to benefit from critical care, but that can mean a lot of things. Does that mean save the most lives, or does that mean save the most life years? Right? Does that mean that younger people get preference over older people? Does that mean that certain types of people get preference over other types of people? One of the concepts with this is that it had to apply to all patients who arrived at the ICU, not just patients with COVID. That if we're triaging the event, we're triaging the event for everybody, not just for patients with the disease of interest. There remains in all of this an obligation to care for all patients. And one thing I like to tell folks is that, like, the machines in the ICU are not magic, right? That we have other ways to support people even if we don't intubate you. And so we need to make sure that if someone wasn't, quote, eligible through a triage rule to get a ventilator, we would still care for them. We still have other ways to oxygenate them. We have still other ways to care for them. Ultimately, it may just come down to palliative care, maybe just symptom control and recognizing there's a fair chance they would pass away. That is still caring. That is still a moral obligation that we have. I have a lot of, by the way, just because this is a small group, I have a lot of sort of like technical doctor abbreviations on here. So if anything I write on here, you wonder like, what does that mean? Just tell me, I'll change it. HHFNC is heated high flow nasal cannula. This is basically a garden hose that lets me blast 100% oxygen into your lungs. It's a non-invasive way to support someone with advanced respiratory failure. It works a lot of the time. Non-invasive ventilation, does anyone ever have someone in their family uses or themselves use like a CPAP mask? It's like a CPAP mask attached to a ventilator. So we can provide non-invasive respiratory support. They're not as good, but they're pretty good. So when we look at these protocols, we have this combination of measures that seek to assess someone's odds of survival. So we look at things like long-term survival. There's a thing called an ASA score, which is a grading scale for whether or not you can undergo general anesthesia, for example. That's a pretty good measure of, if you have a high ASA score, you're probably in pretty rough shape. And you would be, for example, unlikely to survive elective surgery. Frailty indices, and we'll talk a little bit about those. Things called comorbidity indices that sort of like add up your age and all of your various health problems, and they spit out a number and says this is your likelihood of surviving the next 5 years. All of these things were pulled in together to try to figure out who would be likely to benefit from critical care. Short-term survival is looking at like acute organ failure, so like shock or acute kidney injury, acute liver failure, things like that, like you were fine 2 days ago and now you're not, right? SOFA score and Apache scores are two common ways we standardize that in critically ill patients. And then we try to avoid what we call exclusion criteria, meaning that we're not going to write on a list that, like, if you have this disease, we're not going to intubate you or put you on the vent or anything like that. But there are certain groups who we know are unlikely to vent. So like a catastrophic intracranial hemorrhage, right? I attend periodically in our neuro intensive care unit at Baptist, and every so often you'll get someone who just has this massive intracranial bleed, and you can look at the CT scan and you know it's not survivable, right? Coma following return of spontaneous circulation. So television has lied to all of us. You know, you watch like reruns of ER or something, you see someone comes in and we're doing chest compressions and we're shocking and everyone wakes up, and survival after cardiac arrest is about 20%. Like survival and going home neurologically intact is about 20%. So people who we get their heart going again, but they remain comatose, they tend to have a fairly dismal prognosis. You got to give about 3-4 days to figure that out though. And then there's this idea of tiebreakers. Like let's say you have two people who are physiologically identical, but one is a healthcare worker, one is a paramedic, one is a kid. Is that a tiebreaker? Do we preferentially support certain groups over another, right? We were running pretty short on ECMO circuits. ECMO is like heart-lung bypass. Everyone was. And we actually had a cutoff of 45 years old to put someone on ECMO, right? I'm 49. And so I was telling my group, I'm like, so this means you wouldn't cannulate me? You wouldn't put me on ECMO? And the response was, no, we need you to fill the call schedule. So we'll cannulate you, but we expect you to round once you're out of bed. So that was fair. So there are various ethical principles of triage in public health emergencies, right? You are bioethics students by and large, or bioethicists. And so I'm not going to hammer this on you. I say these things to other physicians and it makes me sound deep and insightful, but I think like if I say this to you, I'm going to sound like a moron. But, you know, utilitarian, just what's the greatest good for the greatest number, right? Just a pure question of math. Egalitarian, making sure that we balance this based on need. Libertarian concepts, basically for kind of a first come, first serve notion. Communitarian, looking for respect for sort of social and cultural values. There are certain groups that our culture values more than others. That can be right or wrong. And then again, this consideration for key populations, essential workers, pregnancy, societal leadership, and so forth. A number of my friends, when I was in the military, cared for a prominent member of our government during his COVID-19 attack, and the joke, they were all too discreet to ever say this out loud, but those of us who are on the outside of this said, "We cannot let him die here." and there was, in fact, for high government officials, plans to transfer them for ECMO and advanced cardiac support if that were to happen. So how do you make these decisions? So the idea is we develop these algorithms. And this is from a paper I wrote, which became the guidelines for various critical care societies. But you know what it said was, okay, first of all, does the person need the ICU? Yes, no. If no, then that's that. If yes, do they want the ICU? Because again, for those of you who've been through it, the ICU is no picnic. And some people say, no, thank you, under any circumstances. So then we move on. Do we think they'll benefit from the ICU? And that's where it gets trickier. Does it look like I can help this person? And that's where we start to figure out what we need to do. So the idea in the pandemic was we developed these triage teams. And these teams would be people with experience in acute care. They'd be experienced in taking care of sick people, but they wouldn't be part of the team. They would be a separate group. And what they would do is when an admission came in, they would review their data in a somewhat blinded manner and then say, allocate a ventilator, don't allocate a ventilator. And then we would have to say, take that, right? And the idea would be that it would be lifting this burden from me, that then I would not have the moral distress of having to make that decision, and that it would be fair, that it wouldn't be biased by the impressions of the physician at the bedside, who is by our nature going to try to, fight for the patient in front of us, right? So this was the idea. In this structure, how there's a hospital incident command system, then a triage team, which consists of some physicians, some nurses, administrative assistants. There'd be a review committee, there'd be an appeals process, there would be bioethics input, we'd have this big team and they would make these decisions for us, right? Well, what goes into those teams? What are some of the data? So one of the data points that's used is a thing called a SOFA score. And I mentioned this earlier. This was a sequential organ failure assessment score. The SOFA score is a way of sort of measuring objectively how sick someone is, right? And you get points for kidney dysfunction, for shock, for liver failure, for delirium, for encephalopathy, for things like that. And then you get a number. And so different states used SOFA scores as a number to kind of decide, is someone going to survive their acute illness or not? This is North Carolina's, right here, right? And you had different, depending on your SOFA score and your comorbidity index and a few other things, you'd get a number, and that would then say, if there's a ventilator around, they can have it versus do not allocate, okay? So if you look at, did this make sense? Well, you look at pre-pandemic data. So data from intensive care units that precedes the COVID-19 pandemic. And you see, if you have a very high SOFA score, you're looking at about a SOFA score of 20 or more, you're looking at about an 80% mortality, right? That's someone who's I can probably not help that much, right? So it makes sense that got worked into the protocol. The problem was when you looked at COVID. The SOFA score on presentation did not really predict mortality that well, right? People came in pretty, to coin a phrase, jacked up, and they would often get better. Or they came in looking great and then crashed and burned. It just wasn't predictive. And we saw similar things retrospectively looking at H1N1, that it just wasn't a good tool, but that was the tool we chose. So there's other kind of predictive scores we use. Early warning scores, EWS, so the NEWS is the National Early Warning Score. This was developed by the Royal College of Physicians in the UK. MEWS is the modified one. There's a MEOWS, which is the obstetric version. This was a study that we did. We did a couple of these studies where we said, can we use that score to figure out who is likely to make it when they present with COVID? And it wasn't terribly predictive. The positive predictive value was only a little better than 50. So a positive predictive value is if you get a certain score, what is the likelihood that that's real or not, right? It was a little better than 50%. It was modestly better than a coin toss. And this was another version of the same study we did using a different data set, and we found the same thing. The receiver operator curve is a way of gauging the accuracy of a diagnostic test. It actually comes from World War II and the early use of radar in the Hawaiian Islands. The concept is that if a receiver operator curve of 0.5 is basically a random toss, right? And 1 is a perfect test. 0.7 is what we got under the best possible circumstances, which is good, kind of, but is not enough to make decisions based on, right? I can't make decisions based on a 70-30 odds. I need a little more certainty. There's a thing called the ISARIC 4C score. This was run out of 77,000 patients in the United Kingdom over about a year and a half. No, I'm sorry, about 6 months. And they found that it worked pretty well at predicting outcomes, used different variables. But even then, not great. So the question then becomes, why don't these models work very well? So one thing is that these models were derived from different diseases, right? Bacterial sepsis, influenza, they're different diseases. One of the things they didn't account for was the fact that one of the big features in SOFA scores is hemodynamic instability, like shock, right? Like low blood pressure, not perfusing your organs, shock, right? That's actually pretty rare in COVID, at least up front. That develops later. A lot of these scores are kind of binary. You get you have low blood oxygen or you don't. It's just like a yes/no thing. But there are a million shades of gray of that, right? And these scores don't account for that. And then lastly, bad COVID lasts a long time. People are in the ICU for weeks, right? For weeks. Whereas a bad flu, it's maybe a week, right? So that prolonged nature made it very difficult to predict outcomes. So we had this idea that maybe we're using these predictive models for the wrong reasons. That these models, these scores, they have their purposes, right? They're good for observational data, for observational studies. They're helpful when we're trying to standardize in, say, a clinical trial, how sick is everyone, so that we can describe in the study, are we dealing with a very sick population or a less sick population? That's helpful, right? And that's useful. they are probably a fair screening test for some things. But using them to kind of decide big life or death decisions was premature. Like that was an error. And we probably shouldn't have gone down that pathway. So did anyone ever watch Foundation on Apple TV? Read the books? It's actually a great show. The first season I didn't care for that much, but the second season was, I mean, top-notch science fiction. And Apple, amazing budget for these shows. So there's this notion in psychohistory, which is a fictional thing in these books and in this TV show, is a thing that combines history, sociology, and mathematical statistics to make general predictions about the future behavior of very large groups of people, right? So what this is mathematical modeling that in the context of this fictional book can, and again, great TV show, Apple TV, that can accurately predict the future events on a large scale. But in the books, they make a point of saying this doesn't work on the individual level. What we were trying to do is psychohistory. We were trying to use large-scale mathematical models to predict the outcomes of an individual patient. Also, psychohistory is fiction, right? And that's kind of what it came down to. We were using models for, I think, the wrong reasons. Now, there are some things that may turn out to be a little better. Frailty is one, right? Frailty is age independent. The risk of frailty increases with age, but it is independent of age, right? And there are people who are profoundly frail who we know are not likely to survive an ICU admission, right? And for those patients, we still have a duty to care for them, but we just have to find a better way that doesn't involve doing what I do to them, shoving tubes into their body, sedating them into the point of unconsciousness, making them delirious. We have to find a better way. So there is discussion of maybe frailty is a way that we could do this. And this is from the Lancet, where they look at different clinical frailty scores. And this is a standardized way of assessing how frail someone is, how much time they spend in bed every day, what's their mobility, can they dress themselves, what's their body mass. And says, you know, with advancing frailty, their likelihood of benefiting from the ICU goes down a lot, right? And this was looking at frailty, again, different scores. More advanced frailty is the red line at the bottom. And these people survive ICU admissions very, very infrequently. And even if they survive the immediate ICU admission, a large proportion of them will pass away and never return home, right? And so that's what we're trying to prevent. How about just like clinical assessment? How about if just like an experienced physician or nurse just goes to the bedside and just kind of scans them? How good do? We do about as well as the scores, actually, which isn't to say fantastic, but we're like not much worse. Interestingly, so this was a study done in Switzerland, and what it turned out is that the hospital medicine doctors were actually a little more accurate about who would benefit from the ICU than the ICU doctors are, which I think is probably because we're a little more nihilistic than they are, and they're a little more optimistic about our ability to help them. So it turns out they're right more often than we are about that. But if any of you go to medical school and you become a hospitalist, please forget that you learned that today. So just listen to the ICU. All right, what are some of the other ethical challenges? So role of age. You know, we think about life stages for some. You know, one of the models used in these triage models is, okay, everyone has a right to go through different stages of life. Everyone has a right to grow up, graduate from school, get a job, find a partner if they want, have kids if they want, retire, and, you know, and then go on vacations in the Caribbean or something, right? Everyone has a right to progress through those stages. And should we weight those stages of life differently in a triage model? So maybe. What about kids? You know, does a kid automatically trump an adult? I mean, I think in some cases, but not necessarily. What about the disabled? Right? People living with disabilities, you know, or people with chronic medical problems. You know, there is an injustice because we talked about those SOFA scores. If you have chronic kidney problems, chronic heart problems, you walk around with an abnormal SOFA score, right? And that abnormal SOFA score is not something that like you earned, right? That is the result of many things, including often lifelong difficulty accessing medical care, lifelong challenges of poverty, food insecurity, a million things feed into that, right? So are we shafting people twice? They come in with a high SOFA score, and now we're saying, okay, now I'm not going to intubate you because, you know, 40 years ago your dad lost his job, and you weren't able to go to a doctor until now, right? Like that's not fair. That's not right. So we try to ensure also disproportionate impact on the minority communities. We talked about the comorbidity scores. There's this notion of a thing called an area deprivation index, which is basically like taking your zip code and that sort of adjusts, gives you an estimate based on that and your income level to your access to care, and that would kind of adjust where you fall in a triage system. Doug White at Pittsburgh writes about this. And then, there's the idea, what about just first come, first serve, or just lottery, right? If we can't figure out what's fair, then maybe we shouldn't try. Maybe we should just say first come through the door is who we intubate, right? Now, are there any injustices inherent to that, though? Right? It means first come, first serve, right? That's fair. Except ambulance response time varies depending on where you live, right? And if you have a car, or if you depend on public transportation, all sorts of things make that unfair. I mean, like I said, I'm faculty at Baptist. My son had a medical emergency a couple of weeks ago. I just walked into the ER, right? I was front of the line. I'm part of the tribe, right? That's not true of everybody. It's probably not true of my neighbor, who, retired attorney, just because he doesn't know what buttons to push, other than threatening that he's a retired attorney, I guess. All right. Then there's some legal issues here, right? Declining something that would be normally the standard of care potentially opens us up to liability. If I say to a patient, I'm not going to intubate you, even though that is normally the standard of care, there are legal consequences to that, right? And so one of the discussions is is there a way to protect us, me, from that kind of consequence? And honestly, should I be protected? Should we be protected from that? There needs to be some sort of appeals process, and there really needs to be a government declaration to make these things stick when necessary. And a few places did declare crisis standards, by the way. Alaska, parts of the Southwest did, individual communities, but it can't be like a hospital that does it. It really has to be like a county, a state, the feds. So how did all this work? The short answer is, kind of. So Bob Truog, who's at Harvard, wrote he's actually one of the co-authors on that triage paper that I wrote. Although having Bob Truog as a co-author there's a power imbalance there. We'll just say that in a just and equitable universe, I'd be picking up this dude's laundry. He wrote the Hastings Center report about 1.5 years ago, and he said, sophisticated bioethics for an unworkable strategy. And what he pointed out was that we wrote these very complex plans and no one implemented them as written, right? And the reason is that it's not like there was like an earthquake and all the patients came to the ER at once. They just kept coming. They just never stopped. And so we were never able to take a breather and get the triage team stood up and say, you, right? Like when we had mass cals when I was in Afghanistan, that is what we did. We had a triage officer, but that's because like 30 people showed up at once, right? So we could do that at once. It worked there, but it doesn't work when they keep coming. And so what that left you with is first come, first serve. The thing that I just said is sort of intrinsically unfair. That's what we did. That's what we had to do. These prioritization protocols probably may be effective for less kind of hyperacute things like dialysis, right? Where we can temporize and we can kind of take our time to think about it. One of the things that came up as an alternative was time-limited trials, right? And this is a thing I use with patients on occasion, this discussion. They're like, it sounds like your father, your mother, your spouse is sort of on the fence about whether or not they want some invasive therapy. What I propose is a time-limited trial. Let's do it. I have a week. If we're not seeing progress in a week, then we talk about perhaps transitioning to palliative care, right? Or a week or 3 days or whatever figure is reasonable. But the idea of a time-limited trial, let's give it a shot, but let's not commit you to this forever, right? Maybe time-limited trials are a way around this. Part of the problem is the separation from what we say the bedside intensivist, the person who's actually taking care of them. We talk about these triage teams are separate from the care team. And so this was a group in Germany who wrote about their model. And their model was all of the attending ICU doctors at the hospital would get together and do it together, right? That there was certainly a discussion and consensus in their triage system, But they said, and I actually spoke with the authors of this, they said, we do not believe that it is right for us to abdicate that moral responsibility. That is a heavy burden. I'm not increasing the net joy in the universe if I transfer that obligation to someone else. If someone has it, it should be me, right? And there is some interesting data on saying people involved in triage teams suffer the same moral distress that people at the bedside do. That maybe we're not making the world a better place by transferring that, by abrogating that responsibility. We'll just kind of breeze briefly through healthcare support. If you've read a newspaper in the last few years, you probably see that my people are not having exactly the best year of our lives. It's gotten better. But there still remains a lot of symptoms of moral distress, of strain. There's been a lot of shortages. A lot of people have left the profession. Why was this? Insufficient training in many cases, limitations in PPE, leadership and communication in hospitals was fairly poor in many cases. What are the things that helped? Debriefs. You know, when I'm attending at the end of the day, I kind of get the gang together and say, all right, this went well, this didn't. I love you guys. What complaints do you have? You know, we talk it out, right? Just so like everyone has a chance to be heard, right? Input into working conditions, right? People had very limited input onto what was going on. And then communications obviously seemed to help. It's a bit of a cliche, but it is true. This is totally illegible to you, so I will just skip past it. All right, so what is a good, successful public health emergency response? Good communication with the healthcare systems and between health systems, coordination, fostering this teamwork between systems in advance of an emergency. Hopefully we don't forget everything we learned. And then an accurate inventory of resources. We have to know what we have, right? It was always a little bit of a surprise to find out how short we were on supplies. And having good systems so we know what we have makes it possible to allocate those resources better. A lot of money got spent. A lot of it got wasted. There's been a lot of strikes in healthcare lately. About a year ago, New York nurses all went on a very large strike, which thankfully came to a good conclusion back in California, where I spent most of my career before coming here. Kaiser went on strike. Fortunately, that ended relatively quickly as well. So the bottom line then is that things are not critical. Capabilities are critical. My ability to support someone under anesthesia is critical. My ability to support their lungs, their kidneys, their heart is critical. How we do that, building 20,000 ventilators, is not the point. The point is to maintain capabilities. Things are necessary, but they're insufficient. So a little transport ventilator that we use for like moving people between hospitals is something, and it's a backup plan, but it doesn't replace a full-featured vent. A full-featured vent doesn't work unless you have someone who knows how to use it, right? So, you know, we have to reappraise how we think about this in the context of future emergencies. We have triage plans right now that defy practical implementation. We're not as good at prognosticating, at seeing the future as we think we are. We delayed a lot of things, and a lot of what we called elective care at the time. It was a good decision, but we don't really know what the ramifications of that were. We're just starting to see that now. And whatever we decide, we cannot exacerbate pre-existing inequities anymore. There's been a number of interesting studies saying that, they're all very self-serving, but they're pretty consistent, where they say basically that when people landed in the ICU, there were no racial differences in outcomes. Right? That Black, Latino, white, Asian patients all did the same once they reached the ICU. And I kind of believe that, right? The problem is everything that happened until they got to us, right? Everything that happened before that, right? I went a year without intubating a white person. It wasn't really until the whole anti-vax thing came into play where I started to have large numbers of white people to intubate, right? That was it. But for a year, I went a year. I intubate people for a living. That's what I do. And we can't be caught with our pants down again. We have to support people, rebuild the clinical workforce, establish systems for cooperation and load leveling between health systems, reduce our dependence on sort of single-use goods. But we've been through this before. So this is the old Walter Reed Hospital in Washington, D.C. during the 1918 influenza pandemic. Masks, outdoor ventilation. This was the 1918 campaigns to shame people into following rules, right? Wear a mask or go to jail. This is Javits Center in New York at the beginning of the pandemic. I had a couple friends from the Army who were there. These were volunteers flying to mostly New York at the time. This is my friend Sean. Sean is still in the Navy. He's another critical care doctor. He led one of the response teams down there. The only thing that burnt us in this ABC News report was that they called him a surgeon, and we consider that a slur. Is Ram Stevens. He's a critical care doctor in Wisconsin who's been basically training the entire Ukrainian healthcare system on critical care. So, and this is me. All right. Thanks, guys.
Thank you so much. I apologize for the late start, but we have a few minutes for questions.
Yeah.
People have questions.
Ma'am.
Would you like to field your own question?
Oh, I got it.
Okay.
Yeah, ma'am.
So would it be possible to institutionalize the trials of treatment units?
Yeah.
The reason I ask is because, you know, if you do the first come, first served, you don't have really good triage at the front end.
Right.
You still have things like, well, you know, you're not supposed to be on ECMO forever.
Right.
So we're only going to put you on ECMO for X amount of time.
Yeah.
Could that be done in a way that seems fair enough?
I think so. I mean, I will say that we ran into some challenges with that at Baptist. We had one young man who we were convinced was, we are usually right in this assessment, but we were convinced that he was not going to survive. And he was on ECMO for 2 months, and he did walk out the front door. So every now and then you get burnt by that. But I think certainly on the ventilator side of things, that is very practical. And I think that could be done. Once you've committed someone to ECMO, you're in for the long haul at that point, because especially with veno-venous ECMO, it's a long haul. But I think the idea of a time-limited trial in a public health emergency, I think that should be, my personal opinion is I think that should be institutionalized. I think there's reasonable protocols from overseas that have been adapted, not really turned on, but I have to admit I find it emotionally appealing, the idea that we shouldn't delegate these decisions, right? There are certain tasks that I don't think that we can delegate. There are certain burdens we can't. But I think that after a few days, we have a pretty good idea of someone's prognosis, and the data supports that. And so yes, I do think so. I think that in the next iteration of this, right, like the super polio pandemic of 2118, you know, my great-granddaughter will presumably be writing that paper with that in mind. Ma'am.
Is this the kind of thing where, like, if someone was on a ventilator for like a long time, no chances of recovery, and then someone came in who had a higher chance of recovery, would you take them off?
And that did happen. That did happen. I will say that that never happened to me, but that did happen. Not quite as crassly as it sounds, but yeah, that did happen. That is exactly what I'm talking about. But you would hope to do that in a way, so around 14 days into a course, that's the long end of a ventilator run, right? Most mechanically ventilated patients are on the vent for a week or less. At 14 days is an inflection point where we start to consider tracheostomy, right? Where we create a surgical breathing tube here in the neck, and we take the tube out of the mouth and connect the patient to the vent. Now it sounds fairly horrific, but it's actually more comfortable. You can wake people up, they're less sedated, it's actually less painful, and then as a way to get them off the ventilator, you can connect them, disconnect them. You don't, it's easier, right? And that is a bridge to recovery. But someone with severe refractory respiratory failure at 14 days, you have to be clearly getting better for tracheostomy to even be possible, because part of tracheostomy is you're basically off the ventilator for 10, 15, 20 minutes while we are getting the tube and everything in. If you're too unstable to undergo tracheostomy, that is probably a reasonable branch point where one could say that maybe this is a sort of the end of that time-limited trial. 14 days might be a little too long in some cases, but at least it seems equitable. Now, and I'll say when I'm talking to my own patients, or more often their families, and you know, when I ask them, like, listen, like, I'm hopeful you're going to do okay, but you're meeting me in my place of business, which by definition means this is not the best day of your life. does you or does your loved one have any kind of, advance directives, right? What would you want me to do or not do for you if your heart should stop if you can't breathe? And people often say, well, I don't want to be left on life support. That's kind of vague, right? Like that can mean a lot of things. And so I talk to them about what that means. And often we'll use that tracheostomy point or a time-limited trial as that inflection point for making that decision. And they say, I don't want to be in life support. I think we all generally agree that means they don't wish to be in a long-term care facility attached to a ventilator with a feeding tube in their abdomen for the long haul. We're all very clear about that. So that 14 days is kind of a convenient point because that's when a lot of those things kick in. And why 14 days? The studies that looked at the benefits of tracheostomy at different points all kind of settled on 14 days seems to be the time of maximum benefit without tracheing too many people who don't need to be trached, who would come off the ventilator on their own. So that's why 14. And all things in medicine are multiples of 5 or 7 based on, that's another talk. Sir?
So one of the critiques that you had discussed for the particular models to help guide
Yeah.
triage procedures was that they yielded too little certainty.
Yeah.
I think the highest was the 70-30.
Yeah.
How high would you want that to be in order to actually make decisions on the basis of
If it's life and death, 90, 95. Yeah. I'll give you an example, right? I mean, just so you don't think I pulled that number out of the ether. So there's a blood test called procalcitonin. So we have this challenge in both of my jobs for deciding who needs antibiotics, right? Who needs antibiotics? And so pneumonias, a majority of pneumonias are viral, but I can't tell which ones are viral and which ones are bacterial most of the time. I mean, just by looking at the patient or looking at the scans, I can't tell. I mean, sometimes there's a hint, right? But at that, and eventually, after like a couple days, I can figure it out once cultures come back and diagnostic tests are back. But at that initial moment in a seriously ill patient, we have to make a decision. Who gets antibiotics, right? And there are guidelines saying people with organ failure, you're on the clock. You have 1 to 3 hours, depending on the extent of organ failure, to provide those antibiotics. And that's a quality metric, and it's based in good science, too. That's a good idea. So, and then confounding that, a lot of viral pneumonias will have a bacterial superinfection on it. So even if I identify a virus, that's not sufficient to withhold antibiotics from that person for a superimposed bacterial infection. So there's a blood test called procalcitonin. Procalcitonin is a blood test, is a polypeptide made by follicular cells near our thyroid and other tissues that is upregulated by inflammatory responses that are associated with bacterial infections and is downregulated by interferon gamma, which is part of how we respond to viral infections, right? So that seems cool, right? High procalcitonin antibiotics, low procalcitonin no antibiotics, right? So there was this big study about 5 years ago that that actually analyzed the performance characteristics of that test. The negative predictive value of a low procalcitonin, meaning a low procalcitonin means you don't have a bacterial infection. The negative predictive value is 15%. That is unacceptable to me in the ICU, right? A 15% chance of withholding a life-saving therapy in the acute setting is an unacceptable risk to me. Yeah, so 90 to 95.
We have time for 1 or 2 more questions. I have one if you don't others, but go ahead. I think it's Stephen's chance.
Yeah.
You had mentioned the triage team making
Yeah.
the decisions and alleviating that pressure from the physician.
Yeah.
But were there cases where the physician had negative reactions so that you felt that their expertise would be undermined because they're
Yeah.
the ones interacting directly with the patient?
All the time. Yes, absolutely. We are independent free thinkers. There is no better way to make an ICU doctor angry than override their judgment. Yeah, and that doesn't mean right or wrong, right? It means there's a lot of pride and there's a lot of ego. And that was part of the rationale behind that team, the creation of these teams, is that, listen, if that's the rule and everyone accepts that it's the rule, then people will usually go with it, right? As long as it was fair, as long as it seemed fair. The problem was it was never well implemented, right? It was never fast enough, right? Like pre-pandemic, I had a 19-year-old Marine recruit. This is back in San Diego. I was still in the military. It was a weekend. I was on call. It was just me and a resident. And I walked down to see this young guy who had a parainfluenza 3 pneumonia, right? So a different viral pneumonia, right? And actually was involving his heart muscle. He had myocarditis too. So I walked down to the ER to see him, And he is struggling on this BiPAP mask, this non-invasive mask. He's like tripoding, he can barely breathe. His chest x-ray is just a total whiteout. Like I can't see where his lungs are, it's just white, right? And I look at him, and I look at the emergency physician, who's a friend of mine, and I'm like, dude, either you intubate him or I'm going to, because we have like a minute to do it. And this kid arrested on us 4 times. I coded this guy 4 times. Ultimately, we cannulated him, we put him on ECMO, and he actually survived. He needed a heart transplant, but he survived. But it's a very time-limited decision. And if there's a triage team in the middle of that decision, I don't think they'd have time to do it. I don't think they'd have time to do it well. But for remdesivir, now when we were allocating scarce drugs, where you weren't on a minute-to-minute thing, yeah, then it was really helpful actually, because they really said, like, listen, like this person is less likely to benefit from this drug than that person. So let's, and that's how it's going to be. And everyone was short. Everyone was being said no to on occasion. It was fair, right? And people usually went along with that. They could appeal. There was an appeal process. But yeah, it was fair.
Well, thank you so very,
Oh,
very much.
thank you. Oh, thank you. Thank you for having me.